Hello, my name is Sachin Gujar. I'm the Assistant Professor of Radiology in the Division of Neuroradiology at Hopkins. I will be speaking on CNS infections. We will cover primarily intracranial infections on this talk, and under broad categories of disease, we will include only a few of the potential etiologies of infection. So the outline of the current talk is bacterial infection and complications, mycobacterial infection, viral infections with a focus on herpes encephalitis, fungal disease with cryptococcal infection being covered, toxoplasmosis, then parasitic infection, including cysticercosis, and prion disease. We will talk about CJD. So let us look at these set of images. These are axial flare images of the brain, which show mild ventricular prominence and also slightly increased flare signal within the convexity sulci. You can see that that is brighter than the CSF within the ventricles. So what is the differential diagnosis for a patient with sulcal hyperintensity on the flare images? So the reasons for sulcal hyperintensity on flare images are infections such as meningitis, leptomeningeal increased signal, trauma with subarachnoid hemorrhage, which will result in increased flare signal, vascular indications where in stroke you can see slightly increased flare signal or even enhancement within the meninges. Vascular causes includes the leptomeningeal collaterals in moya with the IV sign. In neoplasms, you can have meningeal carcinomatosis, which can result in increased flare signal. Medications such as supplemental oxygen, as it's given in patients who are undergoing imaging under anesthesia, or you can have failure of fat suppression or fluid suppression as an artifact due to technique. This particular patient had presented with nuchal rigidity, and on the post-contrast images, there is evidence of abnormal enhancement within the sulci. Over the convexity, you can see maybe a little bit of dural enhancement as well, but that is not what we are focused on. We are looking for the enhancement in the leptomeninges that enters the sulci. That is what is positive in patients with leptomeningeal enhancement with bacterial meningitis. So what are the causes of bacterial meningitis? Hematogenous spread is probably the most common cause. You can have direct invasion of infection from the sinuses or the mastoids. Meningitis can occur as a result or a complication of traumatic events or in the post-surgical setting. The organisms that cause the meningitis also differ according to the age and the cause. For example, you have streptococcal or pneumococcal meningitis or meningococcal meningitis in the community setting, or you can have others like Listeria, E. coli, or Staphylococci as well. So the imaging in bacterial meningitis is often normal, but what you can see is increased flare signal within the sulci that is related to inflammation within the meninges as well as increased protein content of the CSF. You can also see leptomeningeal enhancement on contrast enhanced MRI, and more importantly, you'll be able to see findings that are related to complications of meningitis. So what are the complications of CNS bacterial infections or meningitis? One is hydrocephalus, ventriculitis, subdural empyemas or effusions, cerebritis or abscess formation, venous sinus thrombosis, and you can also have arteritic infarcts. So in ependymitis or ventriculitis, how does ependymitis occur? Either you can have direct infection as the result of bacteremia, or you can have an intracranial abscess with ventricular extension, or there is ventricular instrumentation or communication with direct introduction of the infection into the ventricular system. On imaging, you will see ependymal enhancement along the ventricular margins, and you could also see layering fluid levels or debris within the dependent portions of the ventricles, and often that debris, if it is frankly purulent, you might actually see restricted diffusion within. Now, you can have blood products which can cause diffusion restriction, but the combination of enhancement and the layering debris is quite suggestive of ependymitis. For example, in this patient with meningitis, you can actually see a layering flare hyperintense material in the occipital horn, which shows restricted diffusion and enhancement along the ependymal margins of the right occipital horn. You can also see some enhancement within the leptomeninges in the parieto-occipital region posteriorly. Next complication that we will speak about is the development of subdural empyemas. Now, in this patient, you can actually see extraaxial fluid collections over the convexity, which show diffusion restriction and also meningeal enhancement on the surface of the brain. You can also see diffusion restriction within these collections overlying the convexity in the bilateral parietal regions. So imaging of subdural empyema on CT, you expect to see low attenuation subdural collections. Maybe the attenuation will be slightly higher than the CSF density within the ventricles, depending upon the protein content of the empyema. On MR, there will be variable T1 signal, again dependent upon the protein content, and high T2 signal with restricted diffusion, as you may see in an abscess. There's peripheral enhancement, and obviously one surface being the meninges, you will often see gyriform enhancement on the surface of the brain. So in some ways, this could actually mimic a chronic subdural hemorrhage, although there is leptomeningeal enhancement often accompanying. So meningitis can also result in development of parenchymal abscesses. So for example, in this patient with meningitis, and you can see enhancement along the surface of the right cerebral hemisphere, along the lateral aspect in the frontotemporal region, and extending along the anterior portion of the frontal lobes, right more than left. There is a small focal area of increased flare signal at the frontal pole with a rim enhancing abnormality that shows diffusion restrictions centrally. This is a patient with meningitis and with the focal area of cerebritis and abscess formation. So pyogenic brain abscesses can occur as a result of a complication of meningitis, or they could occur as a complication of hematogenous dissemination of infection elsewhere in the body, or from direct extension of infection from adjacent structures resulting in a focal cerebritis with abscess formation, or rarely sequela of trauma. So imaging of a pyogenic brain abscess depends upon the stage of abscess formation. For example, it begins as a cerebritis, where it is poorly marginated with increased T2 and flare hyperintense signal, which then will eventually transform into a well-defined abscess, going through the stages of a late cerebritic phase where there is a greater degree of T2 definition, some peripheral hypointensity developing and surrounding edema, which then forms a more prominent hypointense rim with edema and a capsule formation in the late capsular phase, which is over 2 weeks. On the post-contrast images, of course, you will see a well-defined enhancing lesion in the mature stage with restricted diffusion in the core of the abscess. The capsule tends to be thinner at the ventricular abscess, ventricular aspect of the lesion. The poorly marginated appearance initially with heterogeneous enhancement in the cerebritic phase will result in a well-defined rim enhancement in a mature abscess. There is also diffusion restriction in the central portion of the abscess given the contents, the viscid contents of the abscess. But this is not very specific, nor is it universally present. So about 60% of patients, or 60% of abscesses will actually show diffusion restriction, not 100%, depending upon the stage or the contents in there. MR spectroscopy has also been performed where the central necrotic area shows the presence of lactate, acetate, or even some of the amino acids in there. Typically, this is done with a low TE technique for elucidation of these findings. So this is an example of a parenchymal abscess, large lesion, left temporoparietal rim enhancing abscess with heterogeneous contents, which show restricted diffusion in the portion of the abnormality that is slightly hypo on the T2 weighted images, not so much anteriorly. This is a parenchymal abscess that shows significant surrounding vasogenic edema and the associated mass effect with midline shift. This is an example of a patient who has a brain abscess which is complicated by ventriculitis in there. So the left frontal brain abscess probably entered the ventricular system through the frontal horn, which is not included on this particular set of images. However, you can see that there is rim enhancement along the left ventricular trigone with increased flare signal in the contents of the left ventricular trigone. As you see the axial flare images in this region, there is a mild surrounding periependymal edema around the ventricular trigone, also around the abscess in the left frontal lobe. Abscesses can develop as a result of penetrating injury. For example, in this patient, where you have a fractured or a disrupted squamous temporal bone with an abscess, rim enhancing abscess within the left temporal lobe. This shows mass effect upon the left temporal horn, and there is generalized hydrocephalus seen on these coronal images. Now, abscesses can develop as a complication of a venous infective thrombophlebitis, as for example in this patient who had sphenoid sinusitis, which was complicated by cavernous sinus thrombosis, and the development of abscesses within the brain stem, for example in the right side of the pons and also in the left superior cerebellum, is probably a complication of infection extending along the venous structures to the brain stem. You can also see restricted diffusion within the cavernous sinus portion of the abnormality, the filling defect in the right side of the cavernous sinus. Epidural abscesses are often due to intracranial spread of infection occurring from paranasal sinus disease or mastoiditis. They can occur as a complication of craniotomy or trauma. Onset is often insidious, taking weeks to months, unless there is cerebral complications associated. Overall incidence is not known. Epidural abscesses are far more common in the spine as a result of discitis osteomyelitis, not as common in the intracranial compartment. So, as with other abscesses, the CT shows a low attenuation epidural fluid collection, which may be associated with the sinuses or with the mastoid or under a craniotomy site. On MR, there is variable T1 signal, high T2 signal with restricted diffusion, showing peripheral enhancement. And since the abnormality is associated with the bony structures, there's often an associated abnormality of the calvarium itself or the sinuses or mastoids as maybe the source of the So this is an example of an epidural abscess occurring as a complication of frontal sinusitis. We can see mucosal disease within the frontal sinus, as well as a well-defined collection in the anterior epidural space, as we can see on CT as well as MR images, showing peripheral enhancement. There is also diffusion restriction within the abscess, which posterior displacement of the superior sagittal sinus, and marked dural enhancement along the anterior surface of the frontal lobe, a little bit more on the right as compared to the left. There is obviously mass effect and associated calvarial deformity seen on this example. This is an example of an epidural abscess occurring as a complication of mastoiditis. We can see opacification of the right mastoid and a fluid collection with diffusion restriction and rim enhancement along the posterior occipital region, extending posteromedial from the mastoid in this region. Clearly, there is going to be mass effect upon the dural venous sinuses in this region, for example, the right transverse sinus and the sigmoid sinus, and there is always concern for complications related to the sinuses in these instances. You might also notice that there is infection in the paranasal sinuses on the right side in this particular case, where some diffusion restriction is present within the right anterior ethmoid that shows opacification and peripheral enhancement as well. So epidural abscesses can also extend to the subgaleal space, either via spread from emissary veins or since they are associated with osteomyelitis of the calvarium, you can have abscess collecting on the opposite side or the extracranial portion of the involved calvarium. The pattern of distribution can be similar in an epidural abscess. As for an extradural hemorrhage, for example, it might be limited by a sutural line. And as we mentioned on the previous example, you can have venous sinus thrombosis as a complication, infection, including epidural and subdural abscesses. For example, in this patient with a subdural effusion or collection over the right frontal convexity, we can see a filling defect in the anterior portion of the superior sagittal sinus in the frontal region. The parietal region of the superior sagittal sinus shows normal opacification, but you see a filling defect in the anterior portion, a complication of meningitis and subdural effusion. Let's move on to mycobacterial infections. Obviously, tuberculosis is one of the oldest diseases known to man. 1/3 of the world population is infected with TB. Obviously, a smaller proportion develop disease. This is not very common in all parts of the world. However, we do have infections and tuberculosis occurring in immunosuppressed individuals in this country as well. TB meningitis can be clinically difficult to diagnose. Obviously, they are dependent upon other testing, including CSF analysis. Clinically, there is a non-specific prodrome, and neurologic findings might not be specific given the breadth of involvement that can occur. This is an example of a patient with tuberculosis showing basal meningitis. For example, you can see enhancement within the suprasellar cistern and extending along the surface of the midbrain. There is also presence of small enhancing granulomas in bilateral cerebral hemispheres, for example, in the temporal lobes bilaterally, and there is a rim enhancing abnormality within the right side of the midbrain as well. So this is parenchymal involvement as well as meningeal involvement in this patient with tuberculosis. There is also enlargement of the temporal horns bilaterally, and hydrocephalus is a very common complication in tuberculosis. So tuberculosis results in the various forms of tubercular involvement of the CNS include tuberculous meningitis. There is often preference for involvement of the basal cisterns. There are thick exudates. It's one of those infections which will be easily seen as enhancement even on contrast CT due to the thick exudates. Tuberculomas can occur throughout the brain. You can have either peripheral nodule with enhancement or you can have caseating granulomas or tuberculous abscesses. Vasculitis can occur with infarcts, and hydrocephalus is a common feature of CNS tuberculosis. In this patient with CNS tuberculosis, you again have meningeal enhancement, and this is another example of a tuberculous abscess within the brain stem. And there is a presence of hydrocephalus. As you can see, there is a dilated left temporal horn and transependymal CSF spread in the temporal white matter. Rim enhancing tuberculomas can occur with peripheral enhancement surrounding edema and central T2 hypointense signal. Spectroscopy has often been performed with tuberculomas that show a high lipid peak, and that's due to the lipid in the mycobacterial walls as well. Let us move on to viral infections. Obviously, a lot of viruses can cause CNS involvement. The herpes family of viruses is often the more common source of infection of the CNS, and herpes simplex viruses, Epstein-Barr viruses, CMV, varicella zoster. We know of the multiple other equine encephalitis, the influenza, parainfluenza viral infections. We will focus on herpes encephalitis. There is high incidence in adults and adolescents. Mortality can be very high, or morbidity can be very high without early treatment. The source is thought to be a primary infection or reactivation of latent trigeminal ganglia infection. There is often involvement of the limbic system in patients with herpes encephalitis occurring in adults. MRI findings are characteristic. There is T2 and flare hyperintensity involving the gray matter and subcortical white matter, typically in the temporal and inferior frontal lobes in the periinsular region. There is often bilateral involvement, though it can be asymmetric. There is variable gyroform enhancement with restricted diffusion, and there can be hemorrhagic change. This patient presenting with herpes encephalitis clearly has marked enlargement and abnormality on the FLAIR images in the medial and anterior left temporal lobe. On the diffusion weighted images, you can see that there is diffusion restriction, especially in the anterior left temporal lobe, but you can see perhaps there is a subtle abnormality on the right as well. The follow-up exam shows marked encephalomalacia involving the anterior left temporal lobe and subtle signal abnormalities in the right temporal lobe as a result sequela of herpes encephalitis. This is the example of a patient who had seizures in a postoperative setting of several days after having an excision of a vestibular schwannoma, developing seizures, and MRI shows dural enhancement as a result of the recent surgery and marked abnormalities involving the anterior and medial aspects of the temporal lobe, especially on the right as compared to the left. Mild diffusion abnormalities are also present, and you can see enhancement within the mesial temporal structures, especially on the right side. Let us move on to fungal infections. We will look at cryptococcal infection. Cryptococcus neoformans is the fungus that is usually involved with cryptococcal infections that we see often in immunocompromised patients. A large number of these patients are patients with HIV or AIDS. There is variable clinical presentation, but the common presentation is headache, altered mental status, and raised intracranial pressure. In this patient, let's look at these images in there. These are T2 weighted images showing numerous tiny prominent CSF intensity spaces in the basal ganglia and the thalami bilaterally. Now, this is kind of non-specific because this can be prominent perivascular spaces. On the other hand, Cryptococcus does involve the perivascular spaces and can result in abnormal distension of the perivascular spaces. What you want to notice on these particular images is the abnormal T2 and FLAIR signal or T2 signal in the right superior temporal gyrus. So there is an additional involvement of the parenchyma beyond the basal ganglia in this patient with cryptococcal. So imaging can be normal, or there can be meningoencephalitis, which is a non-specific appearance, as with all infections. So you can have enhancing lesions. The characteristic finding is gelatinous pseudocysts in the Virchow-Robin spaces or the perivascular spaces, and you can have other complications. In this patient with cryptococcal meningitis, we can see prominent meningeal enhancement in the parieto-occipital regions, more on the right as compared to the left. And there is also abnormal FLAIR signal in the basal ganglia bilaterally, as well as in the right thalamus in this patient with cryptococcal meningitis. The characteristic appearance when there is involvement of the basal ganglia is distension of the perivascular spaces by these gelatinous pseudocysts. In this particular patient, there is also presence of meningitis with FLAIR signal in the sulci, posteriorly in the parieto-occipital region bilaterally, as well as ventriculitis with enhancement around the right occipital horn. So these gelatinous pseudocysts can also occur in the posterior fossa, in this example occurring in the bilateral cerebellar hemispheres near the dentate nuclei. Fungal infections can also be a result of angioinvasive infections such as Aspergillus in this patient, causing bilateral cerebritis and almost infarctions of bilateral basal ganglia with rim enhancement and early abscess formation on the left. And the T2 images show small areas of dark T2 signal within the abnormality that could be related to tiny punctate petechial hemorrhages. Toxoplasmosis. Now, this is a parasitic infection that also occurs in immunosuppressed individuals. Toxoplasma gondii is the agent. It is often ingested in material that is contaminated by feline fecal matter or with undercooked meat. There is a high seropositivity in patients with AIDS, where you can have development of toxoplasma encephalitis. Altered mental status, seizures, or lymphadenopathy is also present. They can develop intracranial abscesses. There is propensity of lesions for the deeper structures, for example, the basal ganglia, but there can be peripheral lesions as well, and lesions can be hemorrhagic. This is an example of a rim-enhancing abnormality involving the right thalamus, although there is some enhancement in the left basal ganglia as well. Second set of images showing lesions in the head of the left caudate nucleus and the left basal ganglia with a smaller focus in the right thalamus. So these are lesions associated with toxoplasmosis. This is an example that shows multiple rim enhancing and nodular enhancing lesions scattered throughout the brain parenchyma, which is another example of toxoplasmosis. There is rim enhancement around toxoplasma related abscesses with marked vasogenic edema, but no diffusion restriction is seen in this abnormality seen in the inferior left frontal lobe. You can actually see that there is distension of the right temporal horn, but that could have been a result of the mass effect and effacement of the foramen of Monro, which is not demonstrated on this. So rim enhancing collections with vasogenic edema without diffusion restriction in the core is often a feature of toxoplasmosis. Oftentimes in patients with HIV, and there is a fair amount of literature where the goal of imaging was to differentiate it from lymphoma, and there have been multiple different techniques that have been utilized. For example, thallium SPECT, where lymphoma has high uptake, or diffusion weighted images where the high cellularity of the lymphoma might show diffusion restriction in there. Moving on to neurocysticercosis, this is the most common parasitic infection in the world. Often occurs in young to middle-aged adults, but clearly anybody can be infected. This is most common cause of epilepsy in endemic areas as well. It is caused by pig tapeworm, Tinea solium, with a fecal-oral route of transmission. There can be parenchymal or extraparenchymal involvement. For example, cysticerci can be present in the ventricular system or in the cistern. So neurocysticercosis typically has 4 stages that we can identify on imaging. There is the vesicular stage, where there is a viable cyst with a scolex. There is little or no tissue reaction, so no enhancement and very little edema. This move goes to the colloidal vesicular stage, where the cyst starts degenerating. There is tissue reaction that occurs with edema and enhancement seen, which progresses to the granular nodular stage, which is the degenerating nodule with tissue reaction present. The late stage is the nodular calcified stage, where you might just see nodular or punctate foci of calcification. This is an example of a neurocysticercosis in the vesicular stage, where we see a cyst with a small enhancing scolex visible within. There is the cyst contents themselves are T2 hyperintense and flare hypointense, and you might occasionally identify the scolex on diffusion weighted imaging. This is an example of multiple rim enhancing lesions throughout the cerebral, both cerebral hemispheres, with extensive neurocysticercosis seen in this patient. In the nodular calcified stage, there is focal calcification. In this particular example, we see multiple stages of infection. For example, there are nodular calcifications in the right basal ganglia and in the right parieto-occipital region, and rim enhancing lesions in the left frontal lobe and the right temporal lobe in there. This is the same example that I had shown, the vesicular stage cyst. Earlier in the late stage, this one, the cyst has degenerated and there is a small residual focus of flare signal change and minimal enhancement. In this focus, the enhancement will eventually disappear and leave a focus of calcification behind. So to reiterate, cysticercosis occurs from fecal-oral transmission of the embryonated tinea eggs. So this occurs from contaminated food or water, while teniasis, which is tapeworm infestation, occurs as a result of infected eating infected meat. I have an example of a neurocysticercosis involving the spinal cord. Imaging features are similar. You have a cyst with rim enhancement and surrounding vasogenic edema. which does not look any different from what an intracranial cysticercosis would look like, although the differential diagnosis would also have to include metastases in certain populations. The last condition that we will look at is Prion disease, Creutzfeldt-Jakob disease. The classic clinical history that we are familiar with is rapidly progressing dementia. However, there are numerous other neuropsychiatric disorders and clinical features that are associated with CJD that we are not often aware of in there. The diagnostic criteria are based upon clinical presentation, EEG findings, CSF analysis, and MRI findings. So it's a combination of clinical and lab. On imaging, MRI has characteristic appearance showing restricted diffusion and flare signal change, classically involving the basal ganglia, the caudate head, and the anterior portions of the putamina. There is also flare abnormality and diffusion restriction involving the cerebral cortex in the classic sporadic form of CJD, while there is pulvinar involvement in variant form of CJD. So in this example of CJD, we see increased flare signal involving the heads of the caudate nuclei bilaterally as well as in the putamina bilaterally with diffusion restriction. There is also diffusion abnormality, which is easier to see in the cortex as compared to the flare images in the right more than left cerebral hemispheres. This is a patient with sporadic CJD. On the other hand, in this patient, we see cortical involvement with diffusion restriction more on the left as compared to the right, but there is also evidence of involvement of the medial and posterior thalami with a classic appearance that has been described as a hockey stick appearance due to its shape and involvement of the thalami. This has been a finding described with variants. In summary, we reviewed imaging manifestations and complications of a few common intracranial infections. I want to thank Dr. Harris Sayer, my colleague, who provided me with several cases in this presentation. And thank you, everyone.